Welcome to our video on neuromuscular diseases. Let's get started. Here's our overview slide. We'll be discussing myasthenia gravis, Lambert-Eaton myasthenic syndrome, Duchenne muscular dystrophy, and Becker muscular dystrophy. Let's start with myasthenia gravis. With regards to myasthenia gravis, we'll be discussing the definition, pathophysiology, risk factors, clinical features, diagnosis, and management. So let's begin with the definition. Myasthenia gravis is a neuromuscular autoimmune disease that causes generalized muscle weakness that worsens with use, and the disease affects the young, middle-aged women, and older men. In myasthenia gravis, autoantibodies are targeted against postsynaptic acetylcholine receptors at the neuromuscular junction, and this leads to blockage of signal transmission and degradation of the receptors. Activation of complement can also occur. This all leads to skeletal muscle lysis and weakness. It's also thought that the thymus plays a role in the production of autoantibodies against acetylcholine receptors by dysfunctional T cells. Let's take a look at this image to remember the physiological transmission of signaling at the neuromuscular junction, and this will hopefully help us understand better the pathophysiology of this disease. Recall from physiology that when alpha motor neurons are activated, the action potential causes the presynaptic membrane to depolarize. This opens the voltage-gated presynaptic calcium channels, which leads to the influx of calcium ions and the release of acetylcholine vesicles into the neuromuscular junction. Acetylcholine then will bind to the postsynaptic acetylcholine receptors and cause postsynaptic membrane depolarization and signal propagation. And here's another image from our partnership with Amboss. And if we look at this image, we can see the pathophysiology of myasthenia gravis and how autoantibodies contribute to this disease. Notice that in the first part of this picture, we can see the blockage of acetylcholine receptors by autoantibodies. This leads to signal blockage, and as a result, no muscle is activated. The second part shows acetylcholine receptor internalization and degradation, and therefore muscle weakness. And the third part shows the activation of complement, as well as formation of the membrane attack complex, which leads to muscle cell lysis and muscle weakness. Myasthenia gravis is highly associated with thymoma and thymic hyperplasia. It can also be associated with other autoimmune disorders, such as diabetes mellitus type 1, Hashimoto's thyroiditis, rheumatoid arthritis, and systemic lupus erythematosus. Myasthenia gravis can present in two main clinical forms, the ocular form and the generalized form. The ocular form mostly involves the extraocular muscles and eyelids only, while the generalized form can affect all skeletal muscles in the body. The main manifestation of this disease is muscle weakness and fatigue that worsens with use throughout the day and improves with rest. Under normal conditions, during activity and exercise, the amount of acetylcholine available in muscle cells decreases, especially with repetitive use. Patients with myasthenia gravis experience weakness and fatigue due to the normal decrease in acetylcholine, as well as fewer available receptors. It's important to note that sensation and reflexes are preserved in myasthenia gravis, which is a distinguishing feature of this disease. Involvement of eye muscles are usually the first symptoms, and this can result in ptosis, diplopia, and blurred vision. After that, bulbar symptoms such as dysarthria or slurred speech, as well as dysphagia and facial muscle weakness usually follow. Finally, the involvement of respiratory muscles can lead to dyspnea and hypoventilation. Weakness can later spread to other body areas such as the limbs. This is usually proximal and asymmetrical, and patients can experience difficulty rising from their chairs or brushing their hair. Symptoms can be exacerbated by factors such as pregnancy, drugs, infections, and surgery. Myasthenic crisis is a life-threatening exacerbation of myasthenia gravis that's important to be aware of. It presents with severe muscle weakness and fatigue that involves the respiratory muscles and can lead to respiratory failure. All right, here's another image from Amboss, and this image can help us compare symptoms of myasthenia gravis to Lambert-Eaton myasthenic syndrome, and we'll be discussing this later on in the lecture. Looking at the right side of the screen, we can see that this area focuses on myasthenia gravis, and this is associated with eye muscle weakness, bulbar symptoms, and proximal muscle weakness that worsens with exercise. This is an image of a patient presenting with strabismus and eyelid weakness in a person with myasthenia gravis, and this person is trying to open their eyes but is having difficulty. Strabismus is a condition where both eyes are not aligned and are not looking at the same place. All right, moving on to diagnosis. The best initial test for myasthenia gravis is the acetylcholine receptor antibody test. It's the most specific, but keep in mind that it still could be negative in a small percentage of patients. On electromyography or EMG, the muscle response in myasthenia gravis to repetitive stimulation is described as decremental, which means that it decreases over time. A CT scan should be performed in patients suspected to have myasthenia gravis to look for or rule out the presence of a thymoma. Other tests include the ice test, which is done by applying ice over the eyelids, which should improve the symptoms. This is because the cold temperature helps slow down acetylcholine breakdown at the neuromuscular junction, resulting in more acetylcholine availability in order to bind receptors. The edrophonium or tensilin test was used before the acetylcholine receptor antibody test, but was largely neglected due to its high false positive rates. Nevertheless, it could show up on the boards, so let's take some time to understand the mechanism behind this test. In this test, a short-acting acetylcholinesterase inhibitor is administered, after which patients experience improvement of their symptoms. It works by inhibiting acetylcholinesterase, which increases the availability of acetylcholine that could bind to the acetylcholine receptors, and ultimately this improves signal transmission. Okay, moving on to management. Myasthenic crisis is an emergent condition that needs urgent treatment. In severe respiratory distress, patients may need endotracheal intubation and mechanical ventilation. Plasmapheresis or IVIG can also be done, but plasmapheresis is preferred. Corticosteroids can be given to patients after they have been stabilized. Myasthenia gravis is mainly treated with cholinesterase inhibitors, such as pyridostigmine, which is first line and treats the symptoms. Immunomodulators such as glucocorticoids, azathioprine, as well as IVIG and plasmapheresis can also be used. Finally, thymic surgery should be performed if a thymoma is present. All right, let's try a question. A 37-year-old woman comes to the physician due to progressive muscle weakness and fatigue for the past 3 weeks. She feels like she is more tired by the end of the day and feels better in the morning. She smoked a pack of cigarettes daily for the past 20 years. On physical exam, there is mild dysarthria and ptosis, and generalized muscle weakness is evident more in the upper limbs when compared to the lower limbs. Sensation and deep tendon reflexes are normal. What diagnostic test is more likely to confirm her diagnosis? So this middle-aged woman presents with signs and symptoms of myasthenia gravis. She's presenting with the generalized clinical form, with generalized muscle weakness and fatigue. On physical exam, she has ptosis and dysarthria, which are classic symptoms of myasthenia gravis. Note that sensation and deep tendon reflexes are normal. So the test of choice is the acetylcholine receptor antibody test, which should confirm the diagnosis. After that, imaging such as a CT scan should be performed to exclude thymoma. All right, our next topic will be Lambert-Eaton myasthenic syndrome. All right, again, with Lambert-Eaton myasthenic syndrome, we'll be discussing the definition, pathophysiology, risk factors, clinical features, diagnosis, and management. So let's start with the definition. Lambert-Eaton myasthenic syndrome is a neuromuscular autoimmune disease that causes generalized muscle weakness that improves with use. In this condition, autoantibodies are directed against presynaptic voltage-gated calcium channels at the neuromuscular junction. This leads to decreased calcium influx in the presynaptic membrane, which leads to disruption of acetylcholine release into the neuromuscular junction. So going back to this image, recall that the presynaptic voltage-gated calcium channels are important for the release of acetylcholine. When these are disrupted, signal transmission is impaired due to fewer available acetylcholine molecules. Lambert-Eaton myasthenic syndrome is highly associated with small cell lung carcinoma and is one of the paraneoplastic syndromes associated with this type of cancer. Similar to myasthenia gravis, it could be associated with autoimmune disorders such as diabetes mellitus type 1, Hashimoto's thyroiditis, rheumatoid arthritis, and systemic lupus erythematosus. The presentation is similar to myasthenia gravis in that it manifests with proximal muscle weakness and fatigue. However, in contrast to myasthenia gravis, the weakness worsens with rest and improves with use and exercise. This is a big difference to keep in mind that differentiates these two neuromuscular conditions. The improvement of symptoms with repetitive use happens because the repetitive stimulation causes more calcium influx into the presynaptic membrane, resulting in more acetylcholine to be released, which enhances signal transmission. Lambert-Eaton myasthenic syndrome does not involve the eye muscles and extraocular muscles, and the respiratory muscles are spared. There are also no associated bulbar symptoms like we saw in myasthenia gravis. The reflexes can be decreased or absent. Often, autonomic symptoms such as dryness, constipation, and orthostatic hypotension can also be present, which is not the case in myasthenia gravis. All right, now if we return to this image from Amboss and we focus on the left side of the image, we can contrast the symptoms of Lambert-Eaton myasthenic syndrome with myasthenia gravis. So on the left, we can see dry mouth, constipation, proximal muscle weakness that initially improves with exercise, and reduced or absent reflexes. Keep this image in mind to help you distinguish the clinical presentations of both diseases. On physical exam, repetitive muscle use improves the weakness. This is true for reflexes as well. On EMG, an incremental muscle response is evident upon repetitive stimulation. Finally, laboratory findings can confirm the diagnosis, and this is done when presynaptic voltage-gated calcium channel serum antibodies are present. A CT scan should be performed, which is used to detect small cell lung carcinoma. It's also important to keep in mind that symptoms of Lambert-Eaton myasthenic syndrome do not improve with the edrophonium or tensilin test. And this is because the main problem is with the decreased release of acetylcholine from the presynaptic membrane. Therefore, decreasing the breakdown of these few available acetylcholine molecules by acetylcholinesterase won't help very much. Treatment involves treating the underlying malignancy if present, since about 2/3 of cases have been found to be associated with small cell lung carcinoma. Amifampridine or 3,4-diaminopyridine is first line and works to improve neuromuscular junction signal transmission by increasing acetylcholine release from the presynaptic junction. Similar to myasthenia gravis, immunomodulators such as glucocorticoids and azathioprine, as well as IVIG and plasmapheresis, can also be used. All right, now let's move on to Duchenne muscular dystrophy. Again, just like with the other conditions, let's begin by discussing the definition. Duchenne muscular dystrophy is an X-linked recessive genetic disease that leads to progressive muscle degeneration and weakness. Being an X-linked recessive disease, it almost exclusively affects males. Its pathophysiology stems from the gene mutation encoding for the dystrophin protein, which leads to the complete absence of this protein. The dystrophin protein is a structural protein that's essential for the vitality of muscle cells. Without it, muscle cell death occurs. The main clinical features are progressive muscle weakness and atrophy. The weakness is symmetrical and manifests early in childhood around age 2 to 3. It has a rapid progression, and children often need wheelchairs by the age of 12 due to a complete loss of the ability to walk. The weakness mainly involves the pelvic girdle muscles, but progresses to the rest of the body and eventually affects respiratory muscles, which can lead to respiratory muscle failure. A very important sign of this disease is Gowers' sign, and this refers to the steps that affected patients take when trying to stand up from a seated position. Here is a GIF of a patient with DMD showing Gowers' sign. So notice that this is an image of a patient with Duchenne muscular dystrophy, and the patient is initially on his hands and knees and then goes from this position to trying to stand. And notice that the patient has to support himself by holding his thighs and using his hands in order to eventually reach the standing position. And again, this goes back to the idea that patients with Duchenne muscular dystrophy have muscle weakness, which is most prominent in the pelvic girdle. Therefore, by supporting these muscle groups with his hands, the patient is able to stand more easily. Reflexes are decreased, and patients have gait disturbances referred to as a waddling gait. A classic clinical feature is the pseudohypertrophy of the calf. Calf muscles appear hypertrophied, but it's not true muscle hypertrophy, and this occurs due to fat replacement of muscles. Here is an image showing pseudohypertrophy of calf muscles bilaterally. Involvement of the heart causes dilated cardiomyopathy, which is a common cause of death in these patients. Associated intellectual disabilities and scoliosis can also be seen. In later stages, patients can experience dysphagia and GI disturbances, such as intestinal pseudoobstruction due to decreased intestinal motility. Okay, moving on to the diagnosis. Duchenne muscular dystrophy should first be suspected in a patient with historical and physical exam findings that we just mentioned. Laboratory tests will show significantly elevated serum creatinine kinase and aldolase levels, which are signs of skeletal muscle degradation. To confirm the diagnosis, genetic tests are the gold standard and typically reveal deletion mutations in the dystrophin gene, resulting in an absence of the dystrophin protein. EMG can be helpful and can detect a myopathic pattern of disease. On biopsy, muscle cells appear necrotic, and fat and connective tissue replacing muscle cells will be evident. Here is an image of a biopsy taken from a patient with DMD. Notice the extensive replacement of muscle tissue by adipose tissue. Management is mainly supportive, Physical therapy can help improve ambulation as well as prevent contractures. Respiratory support, such as mechanical ventilation, can be used in patients with respiratory muscle involvement. Patients typically need assisting devices such as wheelchairs to help them ambulate. And surgery can be performed for scoliosis correction and contractive release. Glucocorticoids may also be used, although they're not very effective. And finally, the prognosis is poor, and death usually occurs by 20 to 30 years of age due to cardiac or respiratory failure. All right, let's review with a question. A 5-year-old boy is brought to the physician by his parents due to concerns that he is becoming progressively clumsy. He started walking later than his older sister, around 18 months, but has met all other developmental milestones. On physical exam, he appears pale and anxious. Generalized muscle weakness as well as enlarged calves bilaterally are noted. When asked to stand from a seated position, he crawls up and puts his hands on his knees for support. This patient is most likely to die from which complication? All right, so this patient is presenting with classic signs and symptoms of Duchenne muscular dystrophy. His clumsiness, delayed walking, generalized muscle weakness, and enlarged calves are all indicative of the disease. He also presents with Gower's sign, which is a classic sign of Duchenne muscular dystrophy. This has a poor prognosis, and patients usually die due to respiratory or heart failure around 20 to 30 years of age. All right, our final topic is Becker muscular dystrophy. Becker muscular dystrophy is a progressive muscular dystrophy that is very similar to Duchenne muscular dystrophy, and this leads to muscle degeneration and weakness. Similarly, it's inherited in an X-linked recessive manner, and therefore mostly affects males. Its pathophysiology is similar to DMD, but in Becker muscular dystrophy, the dystrophin protein is decreased and not absent. Therefore, the symptoms are milder, patients present later, and the progression is slower than in DMD. The diagnosis and management are also similar to DMD. And finally, the prognosis of Becker muscular dystrophy is slightly better than DMD. The life expectancy is around 40 to 50 years of age, and patients usually die of heart failure. Here is a table that highlights the differences between Duchenne muscular dystrophy and Becker muscular dystrophy for your review. All right, let's wrap up with one final question. A 39-year-old woman is brought to the emergency department due to weakness, slurred speech, and difficulty breathing. Her history is significant for an upper respiratory tract infection for the past 2 days and well-controlled rheumatoid arthritis. She has also been experiencing increasing muscle weakness for the past 6 months. On physical examination, she has difficulty speaking and keeping her eyes open. She appears pale and anxious with blue discoloration of her lips. Her blood pressure is 116/64 millimeters of mercury, pulse is 106 beats per minute, temperature is 38.2 degrees Celsius, and the respiratory rate is 27 breaths per minute and shallow. The rest of the physical exam, including lung auscultation, is normal. What is the best next step in the management of this patient? A. Pyridostigmine, B. CT scan, C. IVIG, D. Endotracheal intubation, or E. Plasmapheresis. All right, so this patient is most likely presenting with myasthenic crisis. And recall that this is a life-threatening exacerbation of myasthenia gravis that needs urgent endotracheal intubation. So the correct answer is option D, endotracheal intubation. The patient has been experiencing muscle weakness for the past 6 months, and her current symptoms are likely caused by her upper respiratory tract infection, which exacerbated the symptoms of the undiagnosed myasthenia gravis. Hence, she presents with severe respiratory muscle compromise, as well as difficulty breathing, cyanosis, and bulbar symptoms with difficulty speaking and keeping her eyes open. Recall that symptoms of myasthenia gravis can be exacerbated by factors such as pregnancy, drugs, infections, and surgery. Myasthenic crisis is a life-threatening exacerbation of myasthenia gravis that presents with severe muscle weakness and fatigue that involves the respiratory muscles and can lead to respiratory failure. Therefore, it requires urgent endotracheal intubation. Option A is incorrect because even though pyridostigmine is the mainstay treatment of myasthenia gravis, a myasthenic crisis is a life-threatening condition that needs immediate endotracheal intubation. Option B is incorrect because even though a CT scan is used to detect a thymoma in patients with myasthenia gravis, it wouldn't precede life-saving measures. Options C and E are incorrect because endotracheal intubation is needed first to prevent complete respiratory failure. Then plasmapheresis can be done and IVIG can be administered. So again, the correct answer is D, endotracheal intubation. And that concludes our video on neuromuscular diseases.